All right. I'm Chad Rogers. I'm the chair for the board for Arkansas Behavioral Health Integration Network, and we are so glad to have you all here. I see we have some rebels in the back that broke through the lines and sat towards the back, but we encourage you to come down front. But I'm a back row person too. But we're also glad you're here. Hope you were able to get some coffee. There was sort of a little bit of a rush, and we're starting a little bit late. We had traffic getting here. I got here very closely. Four of our speakers just rolled in a few minutes ago, so we're really glad to have everybody here. But it's going to be a really good morning and a good afternoon. We have a great lineup of speakers. We're very excited about the third meeting. This has come together, and people have been so receptive. People signed up very quickly, so we know that people are very hungry and eager for this information. We also have some monthly webinars that go on that kind of continue some education throughout the year, but we're really excited for today. I don't have a whole lot more to say other than just welcome y'all here, and I'm going to pass the microphone to one of our founders, Dr. Patty Gibson.
Yeah, good morning. So this is the third year of this Arkansas Behavioral Health Integration Network Conference. People always say, now what is that? I'm like, ABIN. And then I have to say it all out loud, but Arkansas Behavioral Health Integration Network. I am so thankful that you're here, and it's just amazing because when Kim and I, 2017-18, were thinking about, and we were working in this field, and that's the reason why we're still here. How many years later is because we're like you, that we got the opportunity to take care of patients and work in clinics doing integrated behavioral health. And even though it's been a long ride, and it's still hard for people to understand, what is integrated care and why is it so hard to do? It's so different than what we normally do in healthcare. But the reason that I'm still here and I'm still grateful is because of having that chance to see lives changed in my patients. And sometimes it's not the patient, sometimes it's a family member. Oftentimes it is your other clinicians that are in the clinic. And once they learn that you're there and you're going to be helping them, or it's the clinic managers or the office leads, I'm glad to be meeting some operational people here, that lives really get changed from this type of care. The other thing, not only is there a huge satisfaction for the patients, but there's huge satisfaction for those of us that are the clinicians to really get to do work that matters, because we keep showing up because we want to make a difference. And so I'm really thankful that for you to come here, and I know that you're in store, a treat is in store for you, for the speakers you're going to hear, but also for the people that you're sitting by, for the people that have been working in this field. One of the things is Kim and I were putting together just ABIN. ABIN is not something that said, hey, there's grants, let's create a project so that we can get grant money. ABIN is very much about providing clinical care where need is there to provide increased access to behavioral health, quality care, and make a difference. And that's why ABIN exists. And last night, Kim said to me, you might not know I'm a book person. I'm like, Kim, we are book people. We are people that want to know what is the evidence, what is the research. All of y'all that are clinicians, every day you're going to adapt what you're doing with your patients, with your clients as to what they need. But to really make outcomes, you've got to know what is the evidence, what are the models, what is the research. And that's what, although we have great ideas, we are really trying to base what we're doing on the evidence and on the research. So what we've done always is we say, hey, we're bringing in the evidence into Arkansas, because this is where we want to be. We want to make a difference for the clinicians in Arkansas and the people in Arkansas. And so we've had, every conference we've had has been great. This year, all of our speakers are national experts from outside the state, and they will be talking about the evidence for integrated behavioral health, for different models. They're also people that have been doing this type of work. So we're really thankful that they're here. You're in for a treat. I know sometimes when I go to conferences, I think, well, I'm going to just sit there and have my computer and kind of get some other work done. But I promise you, you'll get a lot out of this if you can take time to really focus on what they're saying you're going to get some real pearls that you can use tomorrow or whenever you go back to work. And that you'll also be able to take some information back to your leadership, to your payers, to wherever, to make this type of care work, because it will make a difference for your clients, for your patients, and for yourself. I did want to call out some people, because conferences like this don't happen by accident. There's a lot of work. And fortunately, I do see Caitlin back there. Caitlin does not like to be called on, and so she's hiding. But I do want to say Caitlin was one of the first behavioral health consultants that worked with me, starting back in 2017. She's done the work. I've seen her grow up. People think she's my daughter, and she tries to avoid that. But she has been has grown into a fantastic leader and a fantastic trainer, and she knows the work. She's done it. And so really appreciate what you're doing, Caitlin. And Misty Trent is probably out front and been a fantastic organizer for us. We bring together people with different skills, and that's what a team-based care is, and that's what we try to do in ABIN. And one of the best things that's happened through this is to get to know Kim Schuler, who is our CEO, who has continued to provide great leadership. And Kim is the real deal. I mean, she's done the work. She's a good person and very strong, ethical, and been a great leader, and has really brought together not only good work for ABIN, but also great work in this conference. So glad to be here, and thank you for all you've done, Kim.
Thank you, Dr. Gibson. I'll tell you, we sure couldn't be here without Dr. Gibson. She has truly been a rock, and she has been inspirational. And you know, this has been a long journey. It's not been an easy journey, but together as a team, we've been able to really continue to grow and advocate the concept behavioral health integration here in Arkansas. I remember in 2004 starting to talk about behavioral health integration, and here I am 21 years later, and we have a conference where we have a room full of people, and we're bringing in national experts, and we're really being able to start to tell the story of behavioral health integration. And so as Dr. Gibson said, today we're going to be hearing from lots of people across the country who have been doing this work, who have been really successful, and they're going to share with us some tips. I also want to say, first of all, thank you to our board. If we didn't have your support and have you all here, this wouldn't be possible. And so we have had a fantastic board supporting us for the past 6 years. Dr. Rogers has been with us all along the way. Dr. Gibson has been here. We've got Denise West, who is a new board member with us. We're so excited. Lee Crow's here with us. So thank you to our board for being here, and thank you for all of the support you're giving us. Also our team. We have a small team, but wow, are they mighty. They have been working effortlessly, and I guarantee you we will go home tired tonight, but tomorrow they will say, hey, Kim, it's we want to get started on the 4th annual conference, and they, for the next year, will take this time, and they will thoughtfully plan out the details to make sure we can have a successful conference. So thank you to our team. I also have to give a shout out and thank the School of Social Work. We have several students here from the School of Social Work. They're supporting us, and want to say thank you to Dr. Ruhr, who's helped coordinate that, and thank you to all of the students. You'll know our team by the green shirts they're wearing. This year we have conference t-shirts, and so if you need something today, please don't hesitate to reach out to myself or someone in a green t-shirt. They'd be more than willing to help you. We are going to be having refreshments, and so we've got breakfast served in one of the side rooms, coffee. Please don't hesitate to make yourself comfortable today. Get up, get some coffee, get refreshments, and we'll have a lunch today. We will have a working lunch. We're having a lunch panel where we're going to feature East Arkansas. We've got Dr. Jones and her team here today. They're going to be talking about the implementation work they've been doing on COCM. And then I want to say thank you to all of our sponsors. This wouldn't be possible without you. You can see we have our sponsors featured here. Thank you to all of our sponsors. We truly, truly appreciate this. And I just have to say thank you to all of you, because without you being here, without your interest, without your passion, without your enthusiasm about behavioral health integration, this wouldn't be possible. And this would stay a concept that we're thinking about, we're reading about, but we're not actually doing. So with that, I'm excited for our first speaker. We have Dr. Kate Hobbs, and I'm going to tell you a little bit about Dr. Hobbs. Dr. Hobbs is a renowned psychiatrist and healthcare executive. Oh, first, I forgot. Before this introduction, I have to do our CEU accreditation. Medco is asking us to have a learner notification, and we will have a QR code at the end of today's conference where you will be getting a CEU certificate. We have 7 CEUs that have been accredited from multiple boards, multiple disciplines, so please stay to the end. You'll get a QR code. And now I'll introduce Dr. Hobbs. Okay, so we have Dr. Hobbs, who we now know is a renowned psychiatrist and healthcare executive with a 20-year career dedicated to improving mental health access and quality, particularly for underserved populations. Throughout her career, Dr. Hobbs has focused on disseminating innovative outpatient care delivery models, measuring outcomes and quality, and transitioning to value-based reimbursement for behavioral health. Currently, she serves as the CEO of Author Health, a tech-enabled healthcare services company offering psychiatric treatment for serious mental illness and substance use disorders. Prior to Author Health, Dr. Hobbs was the CEO of Optum Health Behavioral Care and Chief of Behavioral Health at Blue Cross of North Carolina. Dr. Hobbs served on the board of directors and serves on the board of directors and clinical advisory committees for several healthcare companies, and she is an adjunct assistant professor at Duke University School of Medicine, conducting pragmatic research throughout her work with health systems and payers. Dr. Hobbs, it's been a pleasure getting to know you. Thank you for coming to Arkansas, and thank you for speaking today.
Okay, can you hear me? Everybody hear me? Great. Thank you for the warm introduction, and I'm delighted to be here. I'm really excited about the work that is going on here in Arkansas and excited to share with you some of my experience and then also the national experience that we have in integrated care. One thing to start, we actually have a pretty small room here, and so I would love for you to raise your hand, ask questions, and for us to have as much of a dialogue as possible. I actually don't enjoy just presenting slides for an hour and a half, would much prefer conversation and dialogue. So I may call on you as well or ask questions, so please chime in. A little bit more about myself. So I'm a psychiatrist by background, so I'm a physician, and I trained in both adult and child psychiatry. I've worked in basically every setting, so in inpatient settings, outpatient settings, emergency department, and I've built several integrated behavioral health and primary care programs. So one of my first examples there was right after I finished my residency training, I worked at a federally qualified health center in Boston, and I built our behavioral health integration in primary care. Sometimes I joked that just by walking in the building, being a psychiatrist, I was the integration, which happens sometimes, as you know, but what we're working on and what we'll talk about here is how to make those integrated systems more sustainable and scalable. Also, when I was in Massachusetts early on, I worked for the Medicaid program there. And that's right when Massachusetts was starting to incentivize and deliver value-based payment models to incentivize integrated behavioral health and primary care. And so I had a really cool experience of working at the state to help identify how we could pay for this care, how we could measure quality in behavioral health for FQHCs and other groups that were delivering integrated care. And then I was also working on the ground in my federally qualified health center to be able to participate in those models. And it really brought up all the questions that we have today. We were talking actually on the lift today about the challenges of our workforce actually delivering care within a primary care setting. There's real, even sort of logistical challenges of how you make that coordination work, how we actually work together as teams, and then also how we measure outcomes and report data in a meaningful way to be able to build a sustainable payment model as well. I stayed in Massachusetts until about 2014. I got too cold, and I missed my family in North Carolina. So I moved back to North Carolina, and that's where I live now. I started at Duke, which you saw, and I'm very sad about the game on Saturday night. I don't know if anyone else is a Duke fan, but my husband and I were actually talking about we are uncharacteristically sad. I think it was specifically this team that felt pretty special. Moved back to North Carolina about 10 years ago, started at Duke. I'm still adjunct faculty at Duke, but then quickly got connected in with Medicaid in North Carolina. So I worked at the Medicaid behavioral health MCOs in North Carolina, then moved to Blue Cross North Carolina, and then most recently United and Optum. And so all along that journey working for insurance companies, I was doing certainly core insurance functions like utilization management, case management, network, but always focused more on how do we get high quality care to people in a format and in a timely manner so that it's convenient for them. And so how do we, again, measure quality, build value-based payment models, and deliver care delivery innovations like integrated care to increase access, quality, and outcomes overall. And so that's really the theme of the work that I've done. And then most recently just moved to Author Health, and we'll share a little bit here. Author Health focuses more on severe and complex mental health and substance use disorders and dementia, still in an integrated model, what we call reverse integration, which many of you may have heard, where you lead first with a behavioral health home or behavioral health specialty care, and then bring primary care into that model to increase access to primary care. A few disclosures. Where am I pointing this? 1 second, let me make sure I can advance. Oops. Uh-oh, here we go, I turned it off. I'm sorry. There we go, you guys see so just a few disclosures. So I'm on the board of WELL, which is a health navigation company, and actually on the board of the Alice Walton School of Medicine. So I spend a lot of time actually in Northwest Arkansas, and I'm involved in the Whole Health Institute and the work going on there. Love that work, and I'm excited for that opportunity here in your state. And then I'm an advisor from a behavioral health perspective for these early stage companies. And then next is a picture of one of my favorite family vacations. So this is Northwest Arkansas along the Buffalo River. So this is a view from our campsite. We went about 2 to 3 years ago into that area in the Ozarks. So this is a view from our campsite. These are my children a couple of years ago, where we spent about 3 hours with them on a rope swing in the Buffalo River, and really felt just how serene that environment is, a real sense of calm that was special and unique that I loved here in your state. That experience also just showed me how rural this state is. So I'm from rural North Carolina, and I'm very comfortable and love rural areas. That was a different level of rural than I've ever experienced. And literally, so we were in Bentonville, and then we were driving out. I was amazed by how much space and time there is between each house and each store, how long it takes to go on those windy roads, and really the thought I had over and over again when I was out there was, how would you ever get health care to people in this area? And so that really is a challenge that I know that you have here, and that integrated care can solve, especially for the mental health and substance use issues. And so that's a real piece that we'll talk about here as well, is not only the urban areas like we are now, but how we can also use integrated care to address the rural need in your state. All right. There. Okay. So a few things for foundation, and many of you already know this. We'll talk a lot about behavioral health, and when we say that term behavioral health, it's intended to include both mental health and substance use disorders. So mental health is what you know, depression, diagnoses like depression, anxiety, schizophrenia, bipolar disorder. Substance use disorders describes addiction, so opioid use disorder, alcohol use disorder, et cetera. When I'm referring to both of those, I'll call them both behavioral health. When I'm referring to either one individually, then we'll say specifically mental health or substance use disorders. Another piece of foundation, and we'll have a slide on this in a second, is the different levels of care, right? So many of you know ASAM, American Society for Addiction Medicine. ASAM levels of care from prevention and resilience through outpatient to residential to inpatient care. That continuum exists for mental health and for substance use disorder. Most of the work that we'll be talking about here is mainly in the outpatient setting. So, and you know, many of you agree, almost all behavioral health conditions can be addressed effectively in the outpatient setting. It's a better outcome for people. Most people want to receive their mental health care in their home and in their community and don't want to be in a facility or a hospital. It's a better outcome for patients when we deliver that care in the outpatient setting. It's also better for the healthcare system. It's less cost, and a lot of our high quality treatments are designed for delivery in an outpatient setting. So that's the work, that's the main work that we'll talk about here today. All right, so what are the main problems to solve? And many of you know these. So the behavioral health system, many of us talk about this, behavioral health system is broken. We have major need in our country. We don't have enough providers to address the need. And when people receive care, there's evidence, first of all, we're not really even measuring quality, but even if we were, there's evidence or experience to support as well that the quality of care being delivered today is poor, given the outcomes that we're seeing. So this gives a summary of prevalence rates for mental illness in the United States. And so you can see here on your left, it's describing any mental illness. So around a third of adults in the US have any mental illness. So that's including things like mild depression, mild anxiety, in addition to more serious conditions. On your right here, it describes prevalence rates in our country for serious mental illness as well. And so you can see, again, about 10% of the adults, of the people with any mental illness also have serious mental illness as well. This is a busy slide here. I'm bringing up my stats here as well. This is a busy slide here, but intended to show the breakdown of serious mental illness, substance use disorder, and any mental illness. So over here on the right, what we're seeing is about 25% of Americans, of the total US population, has any mental illness here. And so in the top here, in the top circle, about 11%, 25% of Americans have any mental health or substance use disorder. And then around 10% have any mental illness. That's the top yellow circle up top. And about 7% of the US population has substance use disorder. That's the blue there on the bottom. And then the green in the middle there describes both substance use and mental health conditions, which is about 6%. And then there's a smaller portion, obviously, of those with any mental illness. There's a smaller portion with serious mental illness. It's about 3% of the US population. So that's a lot of people. Like if you look at the millions of adults here that are described, they're at the top. So 7.8 million adults with serious mental illness, and 38 million adults had any mental illness. Like that's a lot of people in the United States with a mental health or a substance use disorder. And the outcomes of these disorders are severe. Suicide rates in the United States are rising, especially among young people. And this shows you in the last year, the proportion here on the left, the portion of youth in the United States that had serious thoughts of suicide. There's certainly dire consequences where children are dying of suicide. Also, it's contributing to issues like ED crowding and hospital crowding, right? Because a lot of these children end up in the emergency department in the hospital, and we don't have adequate resources to treat these youth. At one point in my career, I actually held a child in an emergency department bay for 30 days. So that child didn't go outside and was held there for 30 days, giving her medications to address her PTSD and her suicidal ideation. That's a human rights violation, right? That's not okay for us. And that happens all over the country where the risks are too great for these children to be out and in the community given the issues that they're dealing with, but we also don't have an adequate system to actually serve those needs. That was a big reason that actually prompted me to move more into administration, was those experiences where clearly our system isn't working. Suicide rates are also increasing in elderly adults, and in particular elderly men, also due to firearms. And so in both cases, at all ages, we're seeing increases in suicide and these dire consequences of mental health and substance use disorders. Access to care is limited, as we've talked about, so less than half of people with a mental health condition actually receive care. There's also major disparities. So if you look here at the graph here on the right, African American and Hispanic Americans receive mental health care at about half the rate of whites, and Asian Americans at about a third of the rate of whites. And there's many factors that feed into that, but those disparities also are not acceptable, especially given the outcomes that we're seeing. This is another way to view a similar issue. So of people who have a mental health condition, this is a graph that shows you the portion that have a perceived unmet need for care. So I have serious mental illness here on the right. Around 60% of adults are saying that they had serious mental illness but were not able to access care in the last year. So more problems, workforce shortages. So you all know this. There's not enough behavioral health providers in our country, even in the world, and certainly, and this also is true here in Arkansas. And I'm sorry, the red box there is intended to be around Arkansas. It got a little bit shifted. These behavioral health provider shortages are not going to change in the near term. And we've done lots of work as a country to try to incentivize people to go into psychiatry through financial means, incentivize people to practice in under-resourced areas. There's just not enough psychiatrists and other behavioral health providers, and also those solutions are somewhat effective but don't actually fully solve the problem. And so what we have to do to address workforce shortages is figure out how to use the resources that we have more effectively. Through technology, through things like integrated care, we can make better use of the resources that we have today through these solutions that we'll talk about. And then also inadequate payment. And so many of you have probably seen this as the healthcare Healthcare Action and Learning Network, Learning and Action Network, Healthcare Payment Learning and Action Network, sorry. And it's a helpful diagram, and we will come back to this, to describe the progression from fee-for-service payment all the way to capitated and value-based payment. So this is a really nice slide. Many of you have this where we talk all the time about value-based payment. It means many different things depending on the construct and the patient population. And so we'll spend a little bit of time here because this is foundational, and we'll come back to this several times during the meeting. So category 1 here is fee-for-service, and it's probably what most of us are comfortable with and most of us have experienced. So what it means is anytime you as a provider see a patient in your clinic for a face-to-face or a telehealth visit, then that is a service that was delivered. You submit a claim to the insurance company, and then they pay that claim. That's called a fee. You're getting a fee, a payment, for the service that was delivered. And so the payment in a fee-for-service model is only delivered when you actually have a visit with the patient face-to-face. And one thing that's really important that we're going to come back to, high-quality behavioral health care, right, requires a team. It requires MDs, nurse practitioners, LCSWs, and other master's level clinicians delivering therapy. Primary care. If you're working with kids, you need to be working with the school, with child protective services, with juvenile justice. So a team is required for really high quality behavioral health care. That team and all those services that are done when that are not face-to-face with the patient aren't covered in a fee-for-service model. The only payment is when you actually see the patient and the family and can bill for those services. And so that's really challenging to deliver the high quality care, right? Because most of the services that are effective actually aren't funded in that model. As you move over along this progression, now in category 2, you're actually moving into value-based payment. So the sort of first step into value-based payment is where providers still bill fee-for-service, but then they're also measuring quality and outcomes. And so we could use things like the PHQ-9 for depression or other outcomes that we'll talk about. If you as a provider are delivering good care and moving the needle on PHQ-9, then the insurance company, in addition to your fee-for-service payment, may give you a payment for quality as well. Because not only are you delivering services, but you're also delivering better outcomes. And so you get a pay-for-performance quality payment in category 2. And then categories 3 and 4 are where we move more into more robust payment models. And these are payment models that are more common in the rest of healthcare. So things like ACOs, accountable care organizations that you've heard about, they're really practicing more in these models in categories 3 and 4. What's really useful about those models is that the providers are given funding for that more robust team-based care. So in these models, you actually don't have to see the patient face-to-face in order to get payment. And so all that team-based care, all that coordination with schools and primary care providers would be funded in these categories 3 and 4. It also helps if you think about in terms of cherry picking. So think about this for a second. When you're in a fee-for-service model, and you know this from, or at least I know this from my experience in behavioral health, many clinics, right, are focused on patients that show up, right? And so if a patient is able to show up, be at the appointment, you see the face-to-face, then you can actually get paid. Think about all those patients with active substance use disorder, with health-related social needs, with active psychosis, who really aren't, their working memory is impacted. They're not able to make the phone call, schedule the appointment, get the transportation, get to the visit, show up for that billed face-to-face visit. Those are the patients then that don't end up showing up for care, that oftentimes get fired, right? So if you have 2 or 3 no-shows at a clinic, a lot of clinics have policies where you're not welcome back. And so those are the patients, right, the most vulnerable patients with the active conditions that then don't get served. And so they're left without treatment, with active substance use, active psychosis, and those are the patients that end up in the ED and the inpatient unit in crisis. And it really is this fee-for-service model that sets that up and incentivizes it. It incentivizes us as a behavioral health system to focus on those patients who are healthier, with milder conditions, who are able to show up reliably and end up in care. And so if we're able to move the system over here to more of a capitated model, which we'll describe more in detail in a second, then we're actually incentivized to go find those most vulnerable patients, the sickest patients, and make sure that they get into care. So we'll talk more about that as well. Any questions there? Because this is pretty foundational and is important for us as we think through it. So last piece here, the payment models here in categories 3 and 4 are really based on a population. So this is a model, for example, that our company participates in, where we work with health insurance companies. We identify patients in a particular geography with serious mental illness and substance use disorder, and then those patients get assigned to our company. So now our company is responsible for all patients, for example, with serious mental illness in a certain geography, whether they show up for care or not. And we get paid to deliver care, to go out and engage these patients. And then we're accountable for their total cost and their health outcomes. So we have to show, as a company, for this entire population that they're getting better in terms of their mental health and substance use disorders, that their diabetes is under control, and that their healthcare costs are under control. And if they're not, then we have to give some of that payment back. So the way that system works well, right, is that we get that funding up front. We're able to deliver the team-based care. We're accountable for the outcomes. And then if we don't deliver on the outcomes, then we are financially responsible, which is really motivating for providers to make sure that you're getting those most vulnerable patients into care, keeping them out of high-cost services like ED, inpatient, that are going to drive up cost overall. So we'll talk more about that in a second. All right, so this is a summary of the high costs of our patient population. This is a study from Milliman. That shows, and this is a kind of an old study. It's probably 5 to 10 years old. What it shows across the bottom here, let me see if I can, I don't think I can, okay. What it shows across the bottom here is the different types of payments. So commercial payment, Medicare, Medicaid, and it shows you the average here. These are the total healthcare costs per month. So these are in dollars. So if you're a patient covered by Medicare with a behavioral health condition, your total spend per month is around $1,000 a month. And Medicaid, it's similar. For commercial, it's lower. And then the top here shows prevalence rates. So the prevalence of behavioral health conditions according to payer type. Medicare here is a little bit deflated artificially just because in this study they didn't have access to the pharmacy data. And so the prevalence rates for Medicare are a little bit higher. But you can see the prevalence across the top and then the payment across the bottom. You all know this, that the main drivers of high cost, so these are high costs of total cost of care compared to the general population. The main drivers are actually spending on people's physical health conditions. So to break down this graph, this section over here shows you total cost of care. So again, that's the additional cost of care compared to the prior study. So $1,400 is the average total cost of care for behavioral health compared to the general population of $525 per month. So a difference of about $1,000 for people with behavioral health conditions. If you break down like what's driving that difference in spend, you can look at behavioral health costs, pharmacy costs, medical pharmacy costs, the behavioral health services and the medical services. And so what you see is that it's really spent, for people with behavioral health conditions, the total healthcare costs that are higher are really driven by their physical health conditions. And you know this is true. So all of you have seen patients with depression and co-occurring diabetes and cardiovascular disease. You know that patient, right, is going to be, because of the depression, going to be less likely to eat healthy food, less likely to go on a walk, less likely to take their medicine, show up at the primary care office. And so the impact of that is that their physical health conditions are poorly controlled. The diabetes is out of control, leading to faster progression to end-stage disease, things like kidney disease, eye problems, neuropathy. And so the cost of their medical treatment are much higher compared to people without behavioral health conditions. This is why integrated care is so incredibly important. If we're really going to improve outcomes across whole health, across behavioral health and physical health outcomes, and we're going to drive down costs for across the total cost, then we have to be working with primary care, right? We have to be addressing the behavioral health conditions right alongside people's physical health conditions in order to drive improved outcomes and costs overall. Any questions here? Is this a familiar scenario to you all? You've seen this again and again with patients where, especially in adults and elderly people, the physical health conditions are really out of control, driven by the underlying behavioral health. And so there's good evidence that if we address the behavioral health condition, not only is the depression going to improve, but also the diabetes management, cardiovascular disease, et cetera, will improve. And finally, quality. So many people say that you can't measure quality in behavioral health, which is not true. So many of you know the framework of the quadruple aim and health equity. So the quadruple aim in healthcare is sort of a framework for how we should measure quality. So we should be looking, across all of healthcare, we should aim for total health outcomes to improve. So again, like we said, diabetes, cardiovascular disease, mental health conditions. We want to make sure that people's health conditions are improving. We want to make sure that the experience is high across patients, their caregivers, and providers. And then we also want to measure impact on costs. Again, the things that drive up high cost of care is ED and inpatient care compared to the lower cost settings of outpatient. And then all of these measures should be defined and stratified according to measures of health equity, which are defined here. So we should be measuring, are we seeing improvement in PHQ-9 score equally across different race, ethnicity, age, sex, et cetera. So the summary of the quadruple aim and health equity are listed over here on your left. And then these are specific measures that fall within each domain that we have available to us today, right? So within improving health, many of us know about person-reported health outcome measures. So PHQ-9 for depression. There's other clinically validated scales for mania, for schizophrenia, for caregiver stress, for adolescent anxiety, adolescent depression. So this is called measurement-based care. And in the course of treatment, behavioral health treatment, if we're able to measure a baseline PHQ-9, for example, we're able to understand what the patient's symptoms are at baseline and how severe they are. During the course of treatment, so during your cognitive behavioral therapy or as you're prescribing Prozac or any other SSRI, it would be helpful if we also were measuring PHQ-9 along the way to make sure that the patient is actually getting better during the course of care. Oftentimes what happens today is we prescribe these meds or a patient initiates therapy. We're not actually measuring the outcome, so we don't actually know if it's helping or if it's effective. And you've seen this yourself. Oftentimes I see patients in the emergency department who have been on the same course of treatment for years and it hasn't been effective and no one's really caught that and tried to make a change. And so just like a primary care provider measures your blood pressure when they're treating your hypertension, we as behavioral health providers should be measuring the outcomes, these scales, as we aim to treat the behavioral health conditions as well. And so this is a really important part. It's called measurement-based care, to make sure that the treatment that we're delivering is actually effective. There's other measures that are listed here specific to our patient population. As you know, that specifically for schizophrenia, depression, substance use disorders, there's ample evidence that if patients actually take their meds, so Suboxone, for example, or buprenorphine for a patient with opioid use disorder, there's ample evidence that if we can get patients on these meds, they take them consistently, their behavioral health condition is going to improve, quality of life is going to improve, and all of the other conditions as well. So that's a really important outcome measure that we can be following as well. Again, many of our patients have co-occurring diabetes. Some of our meds actually cause diabetes, so it's important that we as behavioral health providers are also measuring and managing diabetes. And then there's other measures that, again, already exist or clinically validated to make sure that we're adequately working within the system to care for patients, like following up after hospitalization, doing advanced care planning, et cetera. And these are just examples. There's many others of health outcomes that we could be measuring during the course of care and as we care for populations. Improved experience, so Net Promoter Score is one that's commonly used outside of healthcare that we can think about in healthcare. It basically just asks the patient, what is your likelihood of recommending this service or this clinic to a colleague? And so if patients are willing to do that and they're enjoying the service, then the NPS score is higher. If not, then the NPS score is lower. And it would be helpful, again, within behavioral health that we could be really thinking about what patients and caregivers need and their experience to make sure that what we're delivering is actually driving value for them. Similarly for providers, it's very hard work, as you all know here. And what can we do to make sure that the work is sustainable, that we're giving the right supports, that people have the right technology in order to deliver the care in a meaningful way. It's really important that we're also measuring behavioral health provider experience in the course of care. Improved costs, so this is something that can be measured through claims, mostly through health insurance companies and also through value-based payment. When we deliver high-value care, I gave that example of that patient with diabetes and depression. When we as behavioral health providers treat that depression, not only are you going to see them stay out of the hospital for their psychiatric conditions, we also do see through research and experience that they also stop going inpatient for their diabetes and their other medical conditions. And so that's incredibly important for driving down total cost of care within the healthcare system, and really important for us containing costs overall, whether you're in Medicaid, Medicare, or commercial lines of business. And then finally, like I said, taking all of these measures and stratifying them across measures of health equity is important for us to make sure that we're developing an equitable system. So are these measures familiar to people? Is anything new? Yeah. Yeah. And how many, maybe raise your hands, how many are practicing measurement-based care where you're measuring PHQ-9? This is great. Within the course, PHQ-9 or other measures, similar measures. That's a majority of the group here, which is a major progress compared to even 5 years ago, I can be sure. Any challenges associated with that, with measurement? Yes?
Always provider buy-in is a challenge, takes time across time. If your agency or your company isn't also behind it, then they can fall off very easily. It becomes very differential from one practice to another practice, how frequently it's utilized, what utilized to monitor progress. All those kinds of things require diligence across years.
That's exactly right. So lack of standardization, and also, yeah, it requires a lot of work. I mean, these are basically surveys, right? I mean, a PHQ-9 is like a 10-question survey, which is really hard to deliver any survey. You've got to, many providers are still on pen and paper, so you've got to like print the survey, give it to the patient in the waiting room or wherever they're going to do it. Somebody's got to like score it, put it back in the chart, and then somehow you've got to like graph it over time. So that whole process is really hard to do and takes a lot of work. Is important because you're actually going to be able to measure outcomes, but is hard to do, especially when it's unfunded at scale. The other is concern about bias, right? We all know that when we treat patients, oftentimes with depression, the patient is the last one to see that they're feeling better. A lot of times it's the family members who notice that their affect is brighter, the clinician notices that their affect is brighter before the patient starts to feel better. And so it is important that we're measuring the patient experience, but sometimes there's a lag in terms of how they're feeling compared to how the treatment may be going. Other questions or points or experience around measurement-based care? Last thing we'll say is these measures are really important, again, when we're moving towards more of a value-based approach to care. The whole point of a value-based approach is that we're improving health outcomes at the lowest cost. That's value. Value is basically just a ratio of health outcomes in the numerator divided by total cost of care in the denominator. And so this is a really nice framework to say, okay, if we're going to take care of all people in Arkansas with a behavioral health condition, how do we know if we're doing a good job? We would know if we're doing a good job by measuring these outcomes for the population and also measuring their costs. So are we able to get the population healthier and able to maintain costs? These are measures to actually demonstrate that. All right, so just to summarize, those are really a summary of the main problems that we're here to solve. High prevalence of behavioral health conditions, severe outcomes across health outcome, physical health outcomes, suicide, also cost to society in terms of the justice system, in terms of lack of employment, high disability. We don't have enough providers, not going to have enough providers anytime soon, so we've got to figure out how to use the providers that we have more efficiently. We also need to figure out how to measure quality and track quality to ensure that the treatment that we're delivering is effective. And then finally, we have to figure out how to pay for care. It's underfunded today, and so how do we improve the payment and the funding overall? So when we think about solutions, this is a helpful graph. And again, we'll be foundational, and we'll keep coming back to this. So this is a graph. It's called the 4-quadrant model. It was put out by SAMHSA. And this is a simplification of the SAMHSA graph. So across the bottom here, it shows you increasing physical health complexity. So over here, at the intersection here, this would be like no diabetes, no physical health problems, fully healthy adolescent or adult with no physical health problems. And then over here at the most extreme, this would be a patient with heart failure, other cardiovascular disease, diabetes, et cetera, high physical health complexity. And then across the y-axis, there is behavioral health complexity. So down here, the bottom would actually be no behavioral health needs. So think about this a lot with people who don't have any current behavioral problems. Resiliency. So what are we doing to help people reduce stress and increase their resiliency, and protective factors down here where there's low behavioral health need. As you go up this axis on the behavioral health side, mild would be mild depression, anxiety, insomnia, things like that. And then at the very top would be schizophrenia, substance use disorder, really complex behavioral health conditions. And so this graph is helpful because it basically allows you to divide up these 4 quadrants. And so low behavioral health and low physical health. So this is commonly, this group is commonly like adolescents, right, or adults who otherwise are healthy but don't have any behavioral health conditions. And then as you go over, you can imagine people with low behavioral health need but high physical health. So that's the patient, again, we were describing earlier, has diabetes, cardiovascular disease, but mild depression. Their depression absolutely is going to impact their diabetes management, but they don't have severe behavioral health like schizophrenia, for example. And then at the top, you can imagine patients with more severe behavioral health conditions but don't have the co-occurring cardiovascular disease and other physical health needs. And then that top quadrant over there is a patient population we're also likely familiar with, patients with, again, more severe behavioral health conditions and those co-occurring physical health. The highest cost patients, the patients that are driving the highest costs, are over on this side, right? So where there's high physical health need, that's where you're seeing a lot more ED and inpatient visit, both for physical and behavioral health. This is a lower cost patient population here on the right, but still very important, obviously. Adolescents, for example, may not have high healthcare costs, but adolescent mental health needs can be quite severe and deserve treatment. The other nice thing about this 4-quadrant model is that it helps to think about, again, resource allocation. So if we don't have enough behavioral health providers, and we're not going to have enough, if we think about the population that has behavioral health needs according to these quadrants, then we can start thinking about where is the appropriate place to deliver care. And so delivering behavioral health treatment in primary care is really helpful in this low behavioral health category. So here across this axis, so primary care providers are capable of dealing with the full physical health complexity from mild to severe. And they're really good at addressing mild to moderate behavioral health, like depression, anxiety. Around 80, some studies show that 80% of antidepressants actually are prescribed in primary care. And the majority of behavioral health conditions actually are mild to moderate. And so if we could help PCPs better address these lower complexity behavioral health needs, people have better access to their primary care providers, then we could be actually addressing a large portion of the behavioral health need in our country. And then and it actually requires very little input from a behavioral health specialist that is a more limited resource. Additionally, if we did that, then we could be really focusing and reserving our specialty behavioral health providers for the top half of this graph. And so we could be really helping our behavioral health providers to focus in on schizophrenia, substance use disorder, bipolar disorder, severe depression, where our training for that high complexity need is actually most important and is specifically needed for those patients. So does that make sense in terms of thinking about a population, how their behavioral health and their physical health complexity is distributed, and then how then we might think about delivering the appropriate setting of care and also the appropriate providers who would be involved. Any questions there? And then the beauty, again, of this model is that it helps us think through how to use resources more effectively, limited resources more effectively. So let's talk more about integrated care. So why should we integrate care? And so again, this model, this summary here shows again how the physical health and the behavioral health are so inextricably linked. And so why should we integrate care? So the rationale for integrating really differs whether you're talking about adults or kids. So for adults, it's what we just talked about. A lot of the adults have co-occurring physical health conditions, and if we address both, we're going to improve overall health and costs. Integrated care also reduces stigma, and so many people are much more comfortable receiving care in primary care than going to a specialty, especially if you think about, again, small towns. Think about people in the community like people who work in law enforcement or people who work in the schools in a community. Many times in a small community, everyone knows their car, knows who they are, knows their car, knows where they are. Those individuals are going to be less likely to be willing to go park outside of a mental health clinic, right? Because everyone in the town now is going to know that they have a mental health issue that they're dealing with, and that can contribute to stigma. It's much different, right? Everyone should be going to their primary care provider. A lot of times people feel much more comfortable showing up at their primary care provider in order to receive behavioral health care. So it's really important in terms of reducing stigma as well. And then finally, workforce shortages, what we just described. If we can rely more on primary care providers to address the need, we're addressing a large portion of the behavioral health need in our country. For youth, it's a little different. So it's actually rare for kids to be sick at all, right? So it's rare for a child to have any physical health condition or a behavioral health condition. And it's even more rare for kids to have multiple. Now, certainly there are exceptions. There are kids with special health care needs across physical and behavioral health. But it's a relatively small portion of our overall population of children and youth. And so for kids, the main reason to integrate really is access. We don't have enough psychiatrists. If we can support pediatricians to help address these needs, we're going to increase access to care. There's also a question of whether preventive care, so things like immunizations and well child checks, if we were able to support kids around and their families around behavioral health, might we also increase their receipt of preventive care as well? So the value opportunity in adults really is driven by their physical health needs as well. In youth, it's less driven by the physical health impact and more an issue around access. An integrated care continuum. So how many people actually practice in an integrated setting? So about half of us here. So most, and how about practice in just a behavioral health setting, no primary care? Okay, yeah, about a quarter. I'm going to describe the continuum, and then it'll be interesting of those who practice in an integrated setting. It would be interesting to hear where your setting falls along this continuum. So minimal integration is our current state, right? So I'm a psychiatrist. I'm practicing in my clinic here for behavioral health. I know the patient has a primary care provider somewhere in this town, but I'm not connected at all with that primary care provider. And basic at a distance as well. I may or may, after I see this patient, I may or may not send a note to that PCP, right? A lot of times behavioral health providers don't. We just see patients in our clinic. We never communicate with primary care, and so there's very little integration. And it's also just hard, right? It's hard to fax notes and do those kinds of things. Basic on-site integration means that the behavioral health provider and the primary care provider are both at the clinic and on-site. But it doesn't necessarily mean they're communicating. So I've definitely experienced where I'm working in a primary care clinic, we're physically located together, but we're not sharing notes in the EHR, and we're actually not even talking that much. We just happen to be working in the same setting. And then partially integrated and fully integrated is really where we want to be. So in a fully integrated model, you're having a team-based approach to care. You're huddling with your primary care providers. You're sharing notes in the EHR. There's also a shared care plan. So right alongside treatment of that patient's diabetes is the treatment of their depression. And there's close coordination, and also that helps with safety and efficiency of the care that's delivered. And so I'm interested along this. So the people who are practicing in integrated settings, what portion are more here where you're on site, but maybe less actually collaborative and EHR is not integrated? Nice, so none. So who's partially integrated? So you're at least collaborating, you're at least communicating. Maybe your notes are shared, but you're not necessarily huddling at any frequency. Okay, so some. And then what portion are really fully integrated where so a good portion are fully integrated. Anyone want to share the experience? So how did it start, or what's your experience actually working in the fully integrated model? Jump in. How frequently do you huddle? What is it like? Do you want to share?
Sure. I came from being a clinical therapist for about 24 years, and then have been integrated for almost 6 years now at a very large agency, UAMS Family Medicine Clinic. We huddle with the doctors on a daily basis.
Let's see if I can.
Individual doctors and residents. However, we have a weekly meeting on Friday mornings where we are discussing full staff particular cases and what we need to do.
Yeah, so to summarize, works at UAMS. You were a therapist in private practice. Now you're in an integrated setting. And maybe share a little more about how you interact with the PCPs.
Yes, well, of course, any patient that any patient that the doctor, first of all, when the patient goes into the room and then the MA comes in and rooms them, the doctor sees them, or we're given a heads up by either the MA or the doctor. So I believe that our particular clinic really is an integrated clinic. We may even get a call from our access people that are at the very front desk, and they said that someone has expressed a need for a social worker or behavioral health, and so that really gets the ball rolling.
Yep.
So between all of the staff, the nurse case managers, the pharmacists, the dietitians, we all really do talk with one another and pass on needs, which might actually be a resource that,
Yep.
that someone is in need of. We do have a little bit of difficulty where we are a very big clinic, and we put through a lot of people, sometimes up to 140 a day. And then time is of the essence, and so maybe some people may not be caught within the clinic time, and then I'll get a message, please call and make a follow-up call with this particular patient. We try our best to get everybody with the PHQ-9. I think that is increasing lately, and I think the doctors are seeing the importance of following that up behind. I like using the PHQ-9 and the GAD-7 because I'll pick at least 2 different items on there
Yep.
that we can start focusing on as a plan of action, so that I can begin to measure it the next time they come in. How are you doing on that particular plan that we made the last time, so that the patients begin to get that?
That's a beautiful example. And so you see everyone, it sounds like everyone in the clinic is oriented around the behavioral health need. You can absolutely see how access is improved, right?
Right.
Because everyone's focused the minute a need comes up. And before we had such models, then if that need got surfaced, then it would be, okay, well, I'll refer you, and then there's a several months wait, right? And so in this setting, you've got sort of that immediate response that improves access. And then similarly, the use of the measurement-based care also is maybe you've experienced this as well, is helpful for patients, right? And maybe explain a little bit of that experience.
Well, it gives them something to be able to think about when a behavioral health person just shows up in their room. Of course, I explain the integrated system and then what I'm in the room for, looking at what's working for them, what's not working for them, and then just basic looking at either solution for focused orientation or CBT problem solving, giving them something to focus on, some homework to take in their hands, something that they can begin to work on themselves. The doctor is working on their health. They're collaborating with the doctor for a physical health goal, and then we're working on, well, what else is not working in your environment or your lifestyle that you can actually work on a daily basis. And sometimes, of course, using behavioral activation, where many of them, like you said, they're bogged down with their health and medicine and feeling confused and really not knowing where to go, that if I can take them back to that one thing, let's work on sleep, let's work on focusing on your concentration, those things are helpful.
And then, and my experience at least is then as you're repeating that measure, that patient is actually able to see the improvement month over month. And
we have a wonderful EMR where we can, of course, put a reminder on there and exactly have in that note what I've worked with them, and then follow them through the next time that they come. Now, we have so many that the sieve is very small. The funnel is big, but the bottom is very small. But we're working on it.
But it's really reinforcing. Yeah, I mean, there's a lot of structural changes that have to come together to make it work, but that sounds like amazing progress as well. That's great.
Yes.
Any other examples that people would like to share, and also challenges? Yeah, I think we have over here. Over here.
Thank you, Dr. Hobbs, just for your work. And actually, I'm the CEO of the health center. I'll be presenting at lunch, but also I'm an internal medicine physician and been with the health center for a number of years. So thank you for your work in the FQHC world. But I think for me, just busy trying to do all of it, just in a busy primary care clinic, the perfect example was on yesterday. I saw a 37-year-old, had been to the ER, bouncing back to the ER with nausea, vomiting, and had seen several providers in our clinic. And actually, her grandmother, who is 80 years old, brought her in. She's 37 and had been going back and forth to the ER, nausea, vomiting. No one could, find out what was wrong with her. But somebody just said that she probably was suicidal and wanted to do inpatient, and of course she refused. So her grandmother brought her here crying, brought her to me crying. But I think the perfect example on our journey of integrative care was that the LCSW was right there, and the behavioral health care manager ended up having to give her fluids and antiemetics yesterday. And, I've got like 25 more patients to see. So the LCSW came in, and we actually signed her up for the collaborative care program. So it was perfect, and it was just, at its best, the perfect collaboration and integration, and to help this patient. I said, how about we just don't go back to the ER? If you need to call somebody at 2 o'clock in the morning, just call me. So I think for me, just seeing the continuum of how we've grown and integrated our care and allowed much access has been monumental, though.
It gives me chills. What a beautiful example. Yeah. And it's the example, again, around access, also the health outcomes. So her physical health will improve with the treatment that you're giving. Also, clearly, the behavioral health will improve. And you can see how that, in addition to the physical and the behavioral health outcomes improving, also the costs are going to improve, right? If we can keep her out of the ED, out of the emergency department, in the community, it's better for her and her family. That's incredibly disruptive. but also lower cost. I actually would love to hear, if you're open, more experience from the primary care perspective, because I hear that a lot, that sort of the lack of support, and also you know, these patients need a lot of resources that PCPs feel like they can't, or you're managing a ton of things, right? And so adding this in makes it really hard to do this on your own. But if you maybe share a little bit more about that experience.
Well, I think for me, I mean, I get to be the CEO and I'm also a provider, so
Yeah.
I understand in terms of resources and tools
Right.
that are needed. But yeah, I mean, even just trying to integrate this system, yeah, there's a, you know, pushback from some providers, but I think it's because you just don't understand how
Right.
it really can help.
Right.
And I think more and more as providers understand, and I think, you know, also for us, it's just trying to empower that we really can do this. We can really take care of depression and anxiety, and
That's right.
giving them the resources and tools to do that. But I think, and here's my LCSW here right beside me, director of our behavioral health program. But I think we've seen vast improvements, and we've been in different studies. So I think the more that they see the value of
That's
it,
right.
and helping them to, because really, and I say this all the time, that, you know, I'm an internal medicine physician, but and I'm sure you probably maybe experience this, but patients at FQHCs will make you a specialty. They will make you the neurosurgeon, they will make you the cardiologist, because they don't want to
Have
go
the
anywhere
access.
else.
Yes.
And
And
they
they
don't
trust
feel
you.
comfortable. They trust
Yes,
us.
yeah.
The system that they go to with
Yeah.
specialty care is so different. So I think for me is I see the benefit that it brings for our patients, and
That's
of
right.
course total cost, the provider patient experience, and all of that is improved. And of course that health equity piece is also
Yeah.
important as well. So I think for me, I am beginning to get it. I
Yeah.
won't say I don't totally get it, but I think we've made great strides along the way.
Yeah.
Yeah.
I hear that from primary care providers a lot too, that they recognize that there's a need, but don't have the resources, and therefore sometimes don't ask the question, because if they open that box, then where am I going to refer the patient? What am I even going to do here? And so, yeah, having the support there in the clinic allows them to actually start opening up these questions, knowing that they actually have the support. The other thing that these models show that I think is really important for primary care is that it's kind of the adult learning model, right? And so if you have the consultant there, so I'm a PCP, I'm treating depression, I don't know necessarily what to do next. If I can call a consultant, get a response, and then I treat that patient, the next time I see that need, now I know what to do. And so what there is research evidence to show that PCP's ability to treat, and it's focused on mild to moderate, but again, that's the bulk of the behavioral conditions are mild to moderate. If we can support them to learn how to treat that efficiently, then it really does help us solve the problem with the limited resources that we have. So those are great examples. All right. Four components. Again, this is from a Milbank article, and it's what we're all describing here. Common to integrated care. So a person-centered medical home, which FQHCs have really beautifully, and a lot of health systems, et cetera, have the patient-centered medical home. Team-based approach to care. Stepped care, meaning that we try to manage the condition with the least intensive resources possible. So again, trying to address the needs with PCPs or through therapy prior to stepping up to an MD or a nurse practitioner in terms of the resources that are required to deliver the care. And then we just talked about the 4-quadrant model. And so what's the evidence base? So all the good stuff that we're talking about here is what gets borne out in the research. And so there's a lot of research on integrated care, and especially in adults with multiple co-occurring physical health conditions. We see these positive outcomes. Additionally, in youth with behavioral health conditions, we see especially the improved quality of life, the clinical improvement, access to care, and satisfaction. Additionally, there's research showing, this is a study out of Intermountain Healthcare in Utah. So Intermountain is a really interesting healthcare system where they're an ACO. So they have the health system delivering services, and they are integrated with their insurance payer. So they're able to really manage health and costs together in an efficient and an integrated way. And so very early on, they recognize that people, if they're going to manage costs for all the patients that receive care at Intermountain, they're going to have to address behavioral health because of what I showed you. The health costs and the quality or the health outcomes for people with behavioral health conditions are worse than the general population. And so very early on, they recognized that and built an integrated model. And so they have a really, and this is the evidence, but let me just jump ahead. So this model really comes out of Intermountain. And so what they did was they said, okay, for all the patients attributed to or who receive primary care at Intermountain, we're going to stratify them according to mild, moderate, or severe behavioral health conditions. And for those with mild conditions, we're going to have them treated fully with the primary care provider, with a consultant, either a master's level clinician or a nurse practitioner or a psychiatrist, supporting the primary care provider to deliver the care. For moderate conditions, that's where they would bring in a behavioral health provider, and for more severe and complex, they would actually send that patient into their more specialty clinics, but again, still have the specialty providers integrated back with primary care. So this is that example of reverse integration, right? Where you lead with the mental health system, but then make sure that primary care is integrated in with that system. And so this is a really nice model for, again, addressing workforce shortages, addressing total cost of care because you're integrated, but also it's an efficient model in that it matches the resources with the needs of the patient. And it's flexible. So for example, if a patient with severe depression, for example, needs to be treated within the specialty system, they might be treated in the specialty system just for 3 to 6 months, right? To get the depression under control. Those patients do get better. Then they can be referred back to primary care for ongoing treatment, continuation of the antidepressant, et cetera, and therapy. They don't necessarily need the specialty providers. And that's really important because, again, we don't have enough of these specialty providers. We need to keep them open for the most severe and complex. And then we need to create a model where people can go back and forth as their conditions wax and wane. So if that patient with depression who now went back to their PCP has a new exacerbation, it's pretty easy to then come back to this behavioral health provider because they already know them and they're already coordinated across this whole system of care. Any questions there? So what we'll talk about now, and you can also see, remember we talked about that 4-quadrant model. The PCPs are helping to address the patients across the full physical health complexity, but really focused on those lower complexity behavioral health needs. The behavioral health providers are focused on the high behavioral health needs and then are working across with the primary care provider on the physical health needs. And so that's described here. And so now what we'll talk about is the collaborative care model. So the collaborative care model is really focused here in the mild to moderate. And also we'll talk about how to build payment models that support collaborative care. And then we'll give some examples of behavioral health specialty providers, systems, and then also value-based models that can support them. Okay. So this is the collaborative care model. Hopefully it's familiar to everyone here. And so the ideal collaborative care model uses a registry. So patients are identified using PHQ-9 or other means with depression, anxiety, or other behavioral health conditions. They're actually kept on a list within the primary care clinic or registry. And PCPs use registries all the time. They have a list of their patients with diabetes and how are we managing diabetes, cardiovascular disease, et cetera. This is a registry specific to behavioral health. And so the patient is here in the middle. Their PCP is there at the top. And so just like you were just describing within the health system or at the FQHC, or at the FQHC, the PCP is the primary entity that's identifying, can I give you this to put it back together? Is the primary group identifying the behavioral health need, and then is working within this system. So they have a psychiatry consultant. This would be an MD or a nurse practitioner delivering the psychiatric consultant really around the medications and the treatment plan. And then there's a behavioral health care manager that's usually a licensed clinician who's doing a couple of things. One, who's maybe delivering the cognitive behavioral therapy. Thank you. And then also delivering care coordination. Sometimes those roles are split. So sometimes there's a behavioral health, like a master's level clinician who's just doing short-term therapy, and then a separate person who's doing more of the care coordination, because the care coordination needs in this model are pretty significant. A lot of times the PCPs are identifying that actually it's a lot of care coordination needs that are needed here. Any questions or experience here with collaborative care and how this is rolled out? All right, so then we're going to jump into examples. So this is an example here in Arkansas, and you're going to hear many more today. So we've had more examples just in the audience, but then in the discussions today, you'll hear a lot more examples of the collaborative care model. So this is one experience in Arkansas using Concert Health, which is a company that is focused on integrated, delivering the collaborative care model. And so this is an example of around 500 patients that were treated here in Arkansas. You can see the age distribution. So they did have some patients who were children and adolescents. Most patients were adults age 18 to 64. And so in delivering the collaborative care model, the most common conditions were depression and anxiety, which is what we just said. That is what's most commonly brought up in primary care. And so most patients had those likely more mild to moderate conditions. Importantly, they identified many patients, or about a quarter of the patient population was identified at risk for suicide. So again, at the beginning, we talked about in adolescents and in adults that suicide rates are rising. This is a model that is able to catch that risk and also get patients into care to address those needs. This shows you the person-reported health outcomes, so the improvement of the PHQ-9 and the GAD-7 scores over time. And so you can see the baseline scores. A score of 15 is around moderate to severe depression and anxiety. And so you can see that with treatment that those PHQ-9 scores improve. And so that's a great example of delivery here of the collaborative care model and the outcomes that you see. What's not pictured here, obviously, is impact on total cost of care and ED and inpatient visits, but the evidence would suggest, and that evidence the example that I just gave at Intermountain, they are able to show substantial reductions in total medical costs, again, driven by physical health and behavioral health reductions in the inpatient and ED services. Any questions there, or did anyone participate in this model with Concert here in Arkansas? These are great outcomes. So this is a child psychiatry consultation program. So this, unfortunately, we can't watch the video, but I would love to share the link. It's worth watching. So this is a really interesting program. So as you all know, there's not enough behavioral health providers in general. There's certainly not enough providers for children and adolescents, and there won't be anytime soon. And so this is a great model that was developed actually in Massachusetts, and now, and I was involved in it early on in Massachusetts, and now it's spread to almost all states in the country. I think it's in the range of 30 plus states in the country have these child psychiatry consultation programs, and they're here in Arkansas as well. And so the idea here is that, again, a child presents to primary care, to their pediatrician, with a behavioral health need. These are state-funded programs where the PCP can call in, state-run programs. Some of them have some federal funding, but most have state funding. The PCP can call in to the child psychiatry consultation program. They get a call back within an hour, and then they can treat that patient in real time there in the clinic. And so again, if there's questions around diagnosis, if there's questions around medications for this child, or referral to therapy, so care coordination needs, all of that is managed through the child psychiatry consultation program, which is really incredible. Additionally, in some states, if the phone call and the communication with the PCP is not adequate to figure out what's going on, then that child can get referred to a local hub. And so many states sort of have hubs around the state where the child can go for an evaluation with a behavioral health specialist, and then that child goes back to primary care for their ongoing treatment, but now they have the input from the behavioral health specialist for the diagnosis and the treatment plan. And so this has been a really incredible model that has shown increased access to care, improved health outcomes, major pediatrician satisfaction, or primary care provider satisfaction, And also as shown, again, the increase in the primary care providers' ability to manage these conditions independently because they have that support of the consultation with the specialist. Has anybody participated in this type of model before, a consultation program? No. Really phenomenal and a great example of integrating care within primary care to drive the access and the impacts. So now we'll switch to the more severe. So if we're going back to this model here, so now we'll switch to the behavioral health, the specialty provider here. So again, for patients with more severe and complex conditions, if we can lead, oftentimes those patients are comfortable with their behavioral health provider. If we can lead with that treatment and then bring in primary care through reverse integration, that model has been successful. So that's the work the group that I'm working with now. So we've been delivering this care for about the last 2.5 years. It's very similar to assertive community treatment. I tell the team all the time, this is not a new or an innovative model. It's been around for decades. The difference here is figuring out how to deliver these services at scale using telehealth, so being able to especially address need in rural areas, through changing the payment model, so in how we contract with insurance companies to pay for that team-based approach to care, and also through how we use this team and how we work with caregivers to deliver this treatment. So this, again, should look very familiar to anyone who's delivered care in a person-centered medical home or with assertive community treatment. We have psychiatrists, so these are highly specialized MDs and DOs. They're addiction specialists, consult liaison, geriatric psychiatrists, so really specialized clinicians. Again, not many of them in the country. We have licensed clinical social workers and psychiatric nurse practitioners. So across there at the top is the core treatment team. And the treatment that they're providing is diagnosis, med management, psychotherapy, and it's fully virtual. And again, has to be virtual, again, if we're going to be able to deliver care through these specialized services at scale nationally and in rural areas. Many of these patients, as you can imagine, have difficulty using telehealth. So imagine a patient with active psychosis or dementia. Logging onto Zoom can be challenging. And so that's where we have the care management arm here at the bottom that's actually mostly in person. So we have community health workers, so these are people from the local community in areas where there's, like South Florida is one area where we provide services. We have a high population that is Spanish speaking or Haitian Creole speaking. We require that these community health workers are bilingual or trilingual. They come from the local community. They're immediately trusted, right? So from a cultural perspective, they're immediately trusted by the patients with mental health and substance use disorders and dementia. They're going into the home. They're meeting at the primary care office. They're also meeting at the hospital when the patient's in the hospital, all focused on engagement, so helping people build trust and relationship. Also focused on health-related social needs, so housing, food, other barriers to care. And then they literally have a tablet and a hotspot. So if the patient doesn't have the hardware or the ability to use a telehealth model, that community health worker is there to help them connect in with this virtual treatment. And so it's a way to deliver this high-quality team-based care that we know works. It's overcoming the barriers of workforce shortages, of health-related social needs like transportation and internet service, and it's really addressing the holistic needs from a behavioral health perspective. And then we're connected in, and this sort of gives you the view over here. We work really closely with PCPs, so we get referrals from primary care providers. We huddle with PCPs. We share notes with primary care providers. And also we're following up after every physical health admission. So when our patients with schizophrenia are admitted for a medical issue, diabetes, whatever, we are following up with that patient and then connecting them back in with their primary care provider to manage those physical health conditions as well. So this really is that example of how we can be thinking in that 4-quadrant model, right, of the patients with the highest behavioral complexity, really addressing their needs across the full spectrum. This gives you the overview again of how we work with primary care, and this should look familiar. So for the patients with mild to moderate conditions, we're supporting PCPs through consultation. And then for more severe and complex illness, that's where our team sort of takes the lead. And then we connect back in with primary care. And again, this model is flexible, so that patient with severe depression who needs to be treated by our team, when that patient gets better, they go back to primary care for ongoing treatment, and then they can scale up and down this model. And it's a really efficient use of the limited resources and keeps our team available for the most severe and complex. Other thing we're finding is that PCPs feel really comfortable taking these patients back and continuing the behavioral health care because the patients had the consultation or been in treatment with our team of specialists. And additionally, that PCP knows that if the patient has an exacerbation, they're going to have that immediate support again from a team that understands the patient and knows them already. So it's helping leverage the PCP resources as well. This is also a solution for rural health. So again, that experience in Northwest Arkansas where I was sort of overwhelmed by the ruralness. And so these are the ways that we can address those needs. So one is through virtual only. Again, you're still limited by internet access, which is challenging in rural areas. There are primary care providers out in these areas. Again, they're few and far between, but if the patient can get themselves to the PCP office, then they will have internet access and then can use the telehealth services. There's also interesting opportunities through retail clinics. So you've seen that through CVS and Walgreens as those retail clinics bring in primary care, or FQHCs as well. A lot of those are available in rural areas. You can bring in the behavioral health services virtually in those areas. And then finally, the community health workers. So we also offer care in Texas. And so we're serving East Texas in a very rural area. So we have our community health workers actually living in the urban areas nearby. And then on a schedule, they go out. It's a hub and spoke model, right? So they go out to the rural areas on a schedule, and then they see and engage the patients during the week that they're in that rural area. And then they'll go to the other rural areas and then circle back to each space every 2 weeks or every 4 weeks. And so that's a way to get that community health worker resource out into rural areas as well. And then finally, through this model, we've been able to demonstrate reduction in total cost of care. So this is a study that we did against a control group, showing the treatment arm is the orange and the control group is in black. And so it shows about a 13% reduction in total cost of care, inclusive of the payment to author. And so again, we're looking at both physical and behavioral health admissions and costs. And so through this model, we've been able to decrease total costs by keeping people out of ED and inpatient units. This gives you the same study, again, showing the specific impact on inpatients, so about a 50% reduction for both physical and behavioral health. And then for ED, similar, about a 30% reduction in ED utilization, which again is better for the patient. That example that you just gave, these patients and their families don't want to go to the ED over and over again, and it's better for the healthcare system overall. All right, so we'll touch on payment and then wrap up. So again, we'll come back here to this model that, again, was originally demonstrated at Intermountain several decades ago, is a model that I think hopefully looks familiar to you all here, and that also is grounded in that 4-quadrant model from SAMHSA. And so how do we pay for this care? So for the mild to moderate, again, if we can pay for the collaborative care codes and drive adoption of the collaborative care model, that's very sustainable. The other thing here is a lot of times these primary care providers are in health systems that are in ACO arrangements. So what that means is they're a health system that's getting paid by the insurance company to not only improve health for everybody who receives primary care in that health system, but also to reduce costs. And so the PCPs in these health systems, or the health system itself, is responsible for the total cost of care, and for the health. And so if we can include behavioral health measures and behavioral health costs in those models, then that incentivizes the health system to not only address the physical health needs, but also incorporate behavioral health. And then these specialty providers, again, there's specific value-based models that we can develop for the specialty providers. So let's talk first about the collaborative care codes. The collaborative care codes, these are CPT codes that can be reimbursed by Medicaid, by commercial. They are reimbursed by Medicare. There's a list of CPT codes up there. In this model, it's, the psychiatric consultative services are here at sort of the bottom of the triangle. The primary care provider is the one that's billing for the service. And so basically, the psychiatric providers are keeping track of the time that they're spending in the collaborative care model based on the registry. And then monthly, there's a reconciliation where then the primary care practice is billing these CPT codes for those collaborative care services. In many cases, it's actually revenue generating for the primary care practice, and so that's a positive. Some of the challenges, again, are related to some of the administrative work and the actual process of billing. But it is a substantial advance in terms of figuring out how to deliver the integrated care and also pay for it in a sustainable manner. What groups here, if you're practicing with a collaborative care model, where you are actually billing for the collaborative care codes? From a primary care perspective, sounds like maybe none. Yeah, and maybe that's an issue with the coverage of the collaborative care codes here. So again, the codes, the insurance, Medicare insurance does pay for collaborative care via these collaborative care codes, but potentially Medicaid and commercial payers maybe are not paying for these codes as well. So that's an option through adoption, and having Medicaid and commercial pay for these codes would be a way to actually drive adoption of the collaborative care model. Back to this model, again, we talked early on about fee-for-service and the pay-for-performance. A little bit more here on categories 3 and 4. So again, this is an area where usually it's what we call a population-based payment. So the health system or the behavioral health provider receives basically a monthly payment for all patients that receive primary care at the health system, or all patients with a mental health condition that they're accountable for in their area. And this monthly payment basically comes to the provider, and then the provider is responsible for delivering all of the services and staying within the budget. And so it's just like managing your own personal budget. If I'm a provider and I'm getting a payment every month for all the services for patients that receive care in my clinic, if I can deliver all of those services and come in under budget, then I generate savings and I can keep that. If the costs of care are actually over the budget, then I have to pay out. And what we've learned from the rest of healthcare over the last 10 to 20 decades is specifically when a provider is accountable and actually has to pay back the money, then that is incredibly incentivizing for them to build the services that are needed to control costs. So that's what we've seen really over the last 2 decades, where primary care providers have done a ton of, and health systems have done a ton of work to build out case management programs, do a lot of work to engage patients, address health-related social needs, invest in prevention. And it's great because it's incentivized really what we need to see in our health system. And additionally, when I've practiced in these environments in ACOs, when they start to look at what are the main cost drivers here for the population I'm accountable for, time and time again, they see that it honestly is the patients with behavioral health conditions are driving a lot of the costs. And so then they're like, how can I get more psychiatrists? How can I get more master's level clinicians, nurse practitioners here at the table to help me address this behavioral health need? And so it's really an opportunity for us in behavioral health to be at the table, support these health systems and these primary care providers to participate well in these robust ACOs and value-based payment arrangements through efficient models like the collaborative care model. Additionally, so that really focuses on primary care. Additionally, like I said, you can also apply these categories 3 and 4 to a behavioral health provider who takes accountability for health and cost on a population specifically with behavioral health. And then lastly, this gives a summary of some work that we did at Blue Cross North Carolina, where we actually did build out these models for behavioral health providers. So for behavioral health providers who weren't able to necessarily take on the financial risk of having to pay back, we built a model that's category 2, where we continued to do the fee-for-service payment, but we supported them to measure health outcomes using those person-reported health outcome measures, and we did a pay-for-performance model. And then for some providers where they could actually take on that financial risk to be accountable for total costs, we built a model that's more of the category 4 to support those groups. And so, so the basic model here is, this got sort of sorted differently, but basically the pay for performance model was more supportive for the smaller practices to measure quality. And the advanced model, the population-based model, supports the population-based improvement in outcomes and control of costs. And then finally, again, for all of those measures that for both of those payment models that we implemented at Blue Cross North Carolina, these were the measures that we used to measure quality and performance. So we looked across health outcomes, patient and provider experience, and cost, and then stratified all of those according to health equity to measure the impact of the care delivery on the outcomes. So any questions there about payment? All right. So looking ahead, to summarize, behavioral health prevalence is high, really across all ages, and certainly most concerning as we're experiencing increase in suicide rates for elderly people and for young people, and the major impacts socially in terms of our society. Current systems not adequate in terms of not having enough providers, not having the right infrastructure, and then also having an inadequate payment system to deliver high quality care. Integrated care, whether you're talking about mild to moderate or severe, is the solution. There's ample evidence, ample experience that it increases access, increases patient outcomes in terms of their health outcomes, reduces costs. And what we really need to do is focus on how do we get more of that, right? So how do we build payment models, cover the collaborative care codes, be able to support that infrastructure so that we can deliver integrated care really at scale. So any questions further? We got about 5 minutes, I think, left. 7. Oh, okay. So, okay. Any other questions? Great.